Afternoon, friends. It's Friday afternoon, and we are back with another one of our episodes of our Forefront of Future Frontiers, the medical webinar series. We are in series 9. In the series 9, we are exploring how technology has enabled healthcare. So that's the theme for series 9, and we have the talk number 3 today. That is on how the technology has tamed the heart. That's on electrophysiology. And we have with us my dear friend and Professor and HOD of Cardiology, JIPMER Puducherry, Dr. Raja Jayasundar. So he will be speaking to us about this particular topic. So before we start further, I'd request the Dean, Dr. Kutur, to welcome the speaker. Over to you, Dr. Kutur.
Yeah, very good afternoon to all the esteemed participants and the resource person, Dr. Raja. I'm indeed privileged to welcome you for this scientific platform, FFF platform, on behalf of our management, on behalf of our university at large, and on the Chancellor. Just now, Mahalakshmi was sharing information with you that we started this in the beginning of the COVID, and every Friday on this platform, many of the educationists, scientists, teachers, all have shared researchers, share their expertise on and knowledge on this platform. And as I said, you already know this today is the 48th episode. At this juncture, another 200 participants are there, 216. I also like to share the information that on 21st of this month, we are having the Golden Jubilee webinar, FFF webinar, and which will be addressed by none other than the father of evidence-based medicine in this world, Dr. Gordon Guyat, from McMaster University. He will be the one who will be speaking on the subject which he had invented or consolidated the concept a couple of decades back. So that will be of quite interest. And this topic of today's topic, Dr. Balachandar, we also shared this platform some two, three episodes back. And this is of interest. I was just wondering, and I'll be seeing the number of participants will be based on the topic and the speaker. So based on that, I was assuming that so this heart is very, very important for everybody, and going into the intricacies of this, the electrophysiology of heart or electrical activities of the heart, we have the right person. And the advanced technology, you have a hand strip, a head strip, earphone, everywhere from anywhere. You will have inputs to know your heartbeat. You are going in the walking, your phone will give you this kind of a technology we are exposed to. So with this much of background, I'm also very eager to hear from the expert on this topic, what is the recent one or the one useful one. With this, the initial remarks, I welcome Dr. Raja Jayasundar Selvaraj once again for this platform. Thank you.
Yeah, thank you, sir. Dr. Bhatt, would you like to say something?
You'll be introducing him?
Yes, sir.
Dr. Raja, of course, is a well-known cardiologist, and he started the electrophysiology part of cardiology in JIPMER, along with Dr. Balachandar. And they have got a very nice department, and they are well-known all over India for their work. So, Dr. Balachandar talked about sudden cardiac arrest. I think he will concentrate more on how to prevent cardiac arrest before the patient or the individual becomes worse. Because normally when the heart beats regularly, we don't realize heart is beating. But when it becomes irregular, then you realize, okay, there is some problem. So if it is not set right, I think it may cause sudden death or some issues can come up. So thank you, Dr. Raja, for accepting our invitation. And over to Dr. Mahalakshmi.
Yeah, thank you, sir. There we go. Okay. Yeah. Dr. Raja Selvaraj, he's a cardiac electrophysiologist. He actually is a very nice pedigree. He did his MBBS from Kilpack Medical College. He was a classmate of mine. And after that, he went on to do pediatrics from Mumbai and under Dr. Amde. Yeah. And after that, he did DNB cardiology from the railway hospitals. Then he went for his further training in clinical electrocardiophysiciology, that is at University of Toronto. And subsequent to that, when he came back, he has joined JIPMER, and he has actually developed this department, especially the electrophysiology part of the Department of Cardiology. Dr. Balchandar was doing quite a few cases, and he has expanded the scope of services there. He's also editor-in-chief for the Indian Pacing and Electrophysiology Journal. He's a reviewer of many national and international journals with 125 publications to his credit. And more importantly, he's running the fellowship program in cardiac electrophysiology in India. He's got a nice website by himself. So if you go in and see, you can find out a lot more things he's doing. He's a very avid bird watcher. He's a trekker. He plays chess fantastically. He writes codes. He reads extensively. He writes poetry. So he's a extremely multifaceted personality, unlike his classmate who is unidirectional, I would say. So that is Dr. Raja Jaisundar for you. And I hope that he will take today's topic on how technology has tamed heart and make a very interesting presentation. Over to you, Dr. Raja. And before we start, just one announcement for the participants. That is, this session is being recorded and it is also being transmitted live in YouTube. So you can see that on the right upper quadrant of your screen. Okay, so over to you, Dr. Raja.
Good afternoon, everyone. And Mahalakshmi, can you hear me?
Yeah.
Okay.
Loud and clear.
Fine. So thanks to all the organizers for the kind words and the introduction. And I think this is a fantastic forum because it allows a lot of interdisciplinary interaction. And it's nice to be able to talk about this field to people who are not really cardiac electrophysiologists. So I've been involved in this field for close to 20 years, and I think it very well fits the theme of this particular sequence of talks that are going on, which is about technology. Because I think cardiac electrophysiology is an exemplary example of the intermarriage of technology and science. So to start off and introduce the field. The heart beats close to 3 billion times in an average person's lifetime. So, like Sir said, it's something that we're not aware of a lot of the time, but it's a very key integral part of life. And that's why when it's one of the important things you look for to establish death in somebody, that there's no pulse. So pulse is a key of life. And electrophysiology is in a sense a study of the heartbeat and this normal heart rhythm and the disorders of the heart rhythm. So it's a relatively young specialty, really in for only about 30 years, and the number of practitioners of this specialty are still fairly small. And I would say it's a very interesting specialty in its own right. What I'll try to do in this talk is a little bit introduce you to what we do in electrophysiology and focus on certain key aspects of electrophysiology, which really show how technology is involved in this. So heart rhythm disorders is what we deal with. And broadly, we can classify disorders of heart rhythm as those that result in a slow heart rate or those that result in a fast heart rate. So in this talk, I'm going to cover the latter. I'm not going to discuss about slow heart rates. I'm going to talk about patients who have fast heart rates and what we do for them. And in this, I'm going to look at two specific key areas. One is the patients with relatively benign form of fast heart rates, but which is troublesome and where we treat with doing electrophysiology studies and ablation therapy So I'll discuss about how the history of understanding these rhythm abnormalities and treating them has evolved. And the other is a much more dangerous type of fast heart rates, which result in sudden death, and discuss a little bit about how the defibrillators emerged as a treatment for that and where that stands today. So to start with the first topic, what I said was about SVTs. It's a relatively common disorder, and SVT stands for supraventricular tachycardia, which means that the heart beats fast, much faster than it should, and that this rhythm originates not in the ventricles, which are the key pumping chamber, but above the ventricles. So these patients typically present with very rapid heartbeat. They are often young patients with otherwise normal hearts who present with sudden feeling of their heart racing. They may have associated giddiness or breathlessness. Often, like I said, this is a benign condition. It is not usually more than a nuisance. It just keeps coming once in a while. But once it comes on, it may last a few hours. It disrupts somebody's work. It may stop spontaneously, otherwise it may end up requiring the person to go to a hospital and get some medications to be treated. So it is a troublesome disease. And today, most of these patients we are able to cure completely by by specific procedures that we do in electrophysiology. And so the first part of my talk, I'm going to discuss how we learned more about these rhythm abnormalities and how we have learned to treat these abnormalities. So this is how an ECG would look in these patients. So again, I don't want to make this a technical talk, so we're not going to discuss too much about the ECG, but just to say that if we take an ECG, we can confirm that these patients do indeed have a fast heart rate. Here, the ECG shows a heart rate of almost 200 beats per minute, and otherwise the QRS looks relatively normal, like a normal person's QRS, because this is a supraventricular arrhythmia starting above the ventricles. So how did the journey begin of being able to understand this disease and treat it so effectively today? It began with understanding that heart is an electrical organ. So if you think of it, electricity and life forms are not something that you would easily put together. So life is flesh and blood, and electricity is something that runs in your wires and lights up your bulbs. You don't easily think of these as going together. And it was sort of a surprising observation when it was initially noticed. And one of the interesting stories is about Galvani in Italy in 1780s, who saw that if you have a frog leg preparation like this, with a nerve attached to a brass hook, and then then if you stimulate this, if you send an electrical pulse, you see that the frog legs twitch. So the sort of first understanding that electricity has something to do with life and with movement. And remember, this is the 1780s. You don't have electricity easily available to come from a battery or from your wires. So what he had to do was use electricity coming from lightning by doing this experiment during thunderstorms. So at that time, the understanding of this was still a little bit muddled, but still this was a pivotal experiment and slowly led to our understanding that muscle contraction is probably mediated by electrical stimuli. And then as we learned that this electrical activation can be recorded and that heart is also a muscle, we slowly learned to come forward to understand that this heart muscle is also activated by electrical stimuli like this, and that this electrical activity can be recorded. So it was sort of a long road from there, but if you go forward about 100 years later, we have we have fairly sensitive galvanometers, and you can see galvanometer comes from Galvani because he first saw this electricity, and this frog legs, actually the frog leg preparation almost acts like a galvanometer. It is something that detects when electricity is there. So these more refined galvanometers were able to record smaller electrical potential differences. So with these, what we could see is that the potential differences that happen within the heart, that produces small changes on the body surface. And these small potential differences on the body surface could be recorded with these galvanometers, which were fairly accurate. So one interesting person was this Waller, who in the late 1800s did this as a sort of public demonstration. You would go to various places and demonstrate how you could see the electrical activation that was happening in the heart by recording the potentials on the body surface. And the subject he used was his pet bulldog, who was called Jimmy. And so his preparation worked like this. You have a jar filled with saline, filled with salt water basically, and a wire goes from that. And so if the animal steps in with one limb in each of these jars, through these wires which are connected to a galvanometer, you can record the potential difference between this. And this way you could show how the heartbeat can be seen as electrical activity. So this is a very interesting way to demonstrate that you can visualize and see the electrical changes happening in the heart. And among the many people who were watched these demonstrations was Willem Einthoven, who later came to be known as the father of electrocardiography, because he went on to improve and make this a much more accurate system, and then used this to record electrocardiograms in humans and made it a really clinical tool. And really, since the time of Einthoven, the ECG has changed so little. It's amazing that after 100 years, we use ECGs in almost the same form as it was used when it started off. But ECGs still only record things happening on the body surface. So that provides a broad overview of what is happening in the heart and is helpful, helps with a lot of conditions. But we needed some more finesse because before we could record and understand cardiac arrhythmias, which really requires you to record electrical activity from inside the heart. Now, for various organs in medicine, we've used the normal natural portals as a way to reach the organ. So for the lungs, you can reach it from the trachea and the bronchus. For the stomach, you can reach it through the esophagus with endoscopes. So similarly, for the heart, you have veins and blood and arteries connected to the heart, and you can use these as portals to reach the heart. But while people were placing intravenous lines, giving drugs intravenously, there was always a fear about putting a catheter or anything directly into the heart. People thought you would die immediately if you put something into the heart. So there was this sort of eccentric German scientist called Forsman, who thought that it should be possible to place a catheter. When we are placing catheters in the vein, he thought it should be possible to push it further and place it right into the heart. And his primary rationale for doing this was that it will provide a more efficient way to administer drugs straight into the heart. Now, when he got this idea and he wanted to do this, everyone to whom he proposed this was dismissive and did not want to proceed. They thought it was too risky. He was willing to be the subject himself, but still nobody wanted to take that risk with him. So finally, what he did was really trick a nurse into helping him perform a venous cut down and thread a catheter. And then later he pushed that catheter all the way as deep as he could. By this time, the nurse had abandoned and ran away. So with that catheter still inside his body and with it bleeding, holding a towel onto the bleeding arm, he walked up a couple of floors to the radiology unit and got an X-ray to prove that the catheter indeed went into his heart. So sort of an eccentric way to do things, but he finally he shared a Nobel Prize for this, because putting a catheter into the heart was a key advance. It helped with a lot of things, including angiography, and people started recording pressures within the heart. But in terms of electrophysiology, again, this was an important advance, because once you could put wires into the heart on these catheters, instead of seeing broadly the whole heart activation from the body, we could go and see activation happening in smaller areas. So we could go in and see that what happens in small areas of the heart. So today we use catheters like this, which are slender plastic catheters, and these have mounted on them metal electrodes. Each of these electrodes is attached to a wire which comes out on the other end and is used to connect us. So once you put this in the heart, these metal electrodes are in contact with the heart muscle, and they record activity happening within a few millimeters of each of these electrodes. So that way we are able to see precisely activation happening in different regions of the heart. And in a typical electrophysiology study, we may place anywhere from 2 to 4 or 5 catheters like this, each of which has multiple electrodes within the heart. And this is sort of an extreme example, but this is a patient where we had an accessory pathway on the left side. But just to show that we have one catheter coming from the superior vena cava, from a jugular vein puncture. We have 3 catheters coming from the femoral vein into the right side of the heart, and one crossing through a transeptal puncture into the left atrium. And we have one catheter coming from the aorta. Just to tell you that there are various ways to reach the heart, but the basic principle is that we take a catheter with electrodes, place it in multiple regions in the heart, use X-ray to know where it is placed, and then look at the signals which come from it to understand what is happening in that region of the heart. The signals that are recorded go through an amplifier and undergo filtering and are finally displayed on a monitor for us, can be printed out like this, and then we see these signals, and based on what we see in these signals, we can infer the mechanisms of tachycardia. So once this whole system was in place of being able to record intracardiac electrograms, we had the tools to study and understand these rhythm disorders. So technology played a huge part in understanding rhythm disorders. So once this technology was in place, there was an explosion of knowledge in cardiac electrophysiology in the late 1900s, in the second half of the last century. And among the few centers where this sort of exploration started, one of the key places that stood out was Netherlands, where Dr. Dirk Dure's team worked on initial rhythm disorders. So a classic example of a rhythm disorder like this, which is easy to understand and provides a sort of a framework to understand other rhythm disorders, is what is called the WPW syndrome, or the Wolff-Parkinson-White syndrome. So this was described long back by three gentlemen called Wolff, Parkinson, and White. And basically they described a condition where people with no other heart disease have some abnormality on their ECG. They have a short PR interval, and their QRS looks a little abnormal, with the initial part showing a very slurred activation, which is called as a delta wave. Now, patients with these abnormalities present with episodes where their heart starts beating very fast. So they put these together and called it as a syndrome, and called it as the Wolff-Parkinson-White syndrome. Now, studying this, Dr. Dure's team placed catheters inside the heart in these patients. And in addition to placing catheters, what they did is they were able to pace the heart. So they deliver an electrical stimulus through this catheter so that you can capture a certain part of the heart, make it beat. And by delivering this pacing stimulus, they found that in these patients with the Wolff-Parkinson-White syndrome, they can induce this tachycardia. And then with the catheters inside, we can understand how this tachycardia behaves and what is the mechanism underlying it. Before I go into explaining how that happens, again, I want to showcase another piece of technology that comes in here. So it's all these places, a lot of these key advances are based on using technology. So if you remember what I said, Dr. Dure was not passively seeing what is happening in the heart. He was actively manipulating what happens by delivering an electrical pulse. And these electrical pulses have to be delivered very precisely, a certain amount, a certain amplitude, and to be delivered at a certain timing. So to do this, you needed something called a stimulator. So these stimulators, he built it using the bioengineering team in his institute, and these were what were able to deliver these pulses like this to help understand the rhythm abnormalities. Based on these studies, what we understood was that these patients with Wolff-Parkinson-White syndrome have what we call as an accessory pathway. Now, normally the atria and the ventricles are electrically insulated from each other everywhere except for the normal atrioventricular conduction system. If you have any other electrical connection between the atria and the ventricles, it is called an additional connection or an accessory pathway. So because these patients with Wolff-Parkinson-White syndrome have an accessory pathway, during sinus rhythm, the ventricle, in addition to being depolarized through the normal conduction system, is partially depolarized by the accessory pathway, and this is what produces the delta wave. And these patients get tachycardia because when there are two pathways, what can happen is a condition called as reentry. So normally, the electrical activity on the heart, each electrical impulse should produce one heartbeat. Producing one heartbeat, it should just extinguish, and then the next heartbeat should only be produced by the next electrical impulse. So this is normal. But what can happen when you have two pathways like this is that one impulse that comes down from, so the upper part here is the atrium and this is the ventricle. So one impulse that comes from the atrium to the ventricle can re-enter the atrium through the second pathway, and then can again re-enter the ventricle through the first pathway, and so on, and so initiate what is called as re-entry. So it proceeds in a cyclical fashion where the same electrical impulse, instead of getting extinguished, continues to produce repetitive heartbeats. So this results in tachycardia. So understanding this as the basis of Wolff-Parkinson-White syndrome was a major advance. And also it provides a template, because based on this, we can understand the different forms of re-entry. In another common form of reentry, what is called as AV nodal reentry in tachycardia, there are two pathways again, but these two pathways are located within the AV node itself, and thus they form a circuit. But once we know this is the mechanism, that there is a normal conduction system and there is an abnormal conduction system, and presence of these two conduction pathways results in reentry, then the treatment obviously can be directed towards destroying this abnormal conduction system so that that does not function anymore. Once this abnormal conduction system is destroyed, the normal conduction system will still be functioning so that it will be back like a normal heart, but these patients will not develop tachycardia. But how do we destroy tissue within the heart without doing surgery? So because we have catheters already placed here recording electrical activity, can we use these same catheters to deliver some form of energy to destroy tissue? So that was what was explored first. And the initial explorations used direct current, DC. So DC is, like this is a defibrillator where we use this for defibrillation. And if this same shock, instead of giving it on the body surface, we can connect this to an electrode and deliver it inside the heart, it can damage a small portion of tissue at the point where the DC comes out of the electrode. So using this, the initial few ablations were performed, and this is successful but has a few risks because little uncontrolled form of therapy. Today, what we use is called radio frequency. So this is again just energy at a specific frequency range. If you use very high frequencies, you get dielectric heating, that is like heating at a distance, and that is what is used in microwaves. Whereas if you use very low frequencies, you get muscle stimulation. So this is what we use in pacemakers. A pacemaker, for example, might pace at 1 hertz. 1 hertz is 1 times a second, so you will get a heart rate of 60 beats a minute. Whereas if you're pacing at around, if you deliver a waveform at a frequency of around 1 megahertz, this is called as radio frequency. And this radio frequency, when delivered through a catheter, produces heating at the catheter tip, and this heating destroys about 5 millimeters of tissue around the catheter. By varying the amount of energy or the size of the electrode, or sometimes by using irrigation, by delivering cold saline to cool down the tip, we can alter the size of the lesion that we produce. But ultimately, we produce tissue heating and a lesion and can destroy tissue. The other, so relatively from the time this was developed over the last 30-40 years, electrophysiology study has remained about the same. But one advance that has happened recently and which we use now for complex arrhythmias is what is called as electroanatomic mapping, which means that instead of only collecting electrical information from the signals on the catheters, we can now collect anatomic information, which means geometry. We can know where an electrode is located in space. And then based on this geometry, we can create a shell of the whole heart. We can create a geometry of the heart. And in a three-dimensional way, you can look at electrical activation of the heart. So this allows us to treat more complex arrhythmias. We can see how an electrical wavefront propagates within the heart. So here, for example, we're showing the right atrium in a condition called right atrial flutter. And this white wavefront that we see is how the electrical wavefront is propagating across the right atrium. And we can see how flutter happens due to reentry here. And we can see how better ways to treat this. So this has been a more recent advance. I'm not going to go into details in this because of time. But just to summarize that part, we have a lot of patients who present with sudden episodes of rapid heartbeat, and most of these are supraventricular tachycardia, and these have been well understood now with the use of intracardiac electrograms, and these have become a very routine condition which we treat every day using radiofrequency ablation. Switching gears, coming to the second part of the talk, where instead of sometimes a rapid heartbeat is not so benign. Sometimes a very rapid heartbeat is something that can be fatal and can result in sudden death of a person. So I don't need to introduce you to introduce Professor Dr. Abdul Kalam to you, who's been one of the most beloved presidents of our country. 2015, he was delivering a talk at Shillong, and he collapsed on the stage and died. So this is something that happens every day, but is not that well recognized or well known, that sudden deaths are a very major and important cause of death. we have fairly good statistics from the United States, not that good data from from India. And what data we have in the United States tells us that about 15% of adults may have the cause of death may be sudden death. So sudden death is basically when when a person who's otherwise well, who has been well in the last 24 hours, collapses and dies suddenly. So when it happens this suddenly, most of the time it is due to a heart disease, and most of the time it is due to a cardiac arrhythmia. So because sudden death is such a prevalent problem, that is why CPR is promoted so much, and people are taught CPR, because early bystander CPR can help resuscitate some of these patients. But CPR makes you think that it's the heart has stopped and we're somehow trying to start the heart. But that's not true. The heart is not pumping efficiently and there's no blood flow. So what chest compression during CPR does is it produces some pulsatile flow to keep the brain alive while some definitive treatment can be undertaken. But in patients where rhythm has been recorded during episodes of sudden cardiac arrest like this, what is seen is that the rhythm usually is what is called as ventricular fibrillation, which is a rapid chaotic beating of the ventricles resulting in no effective pulse. Which is why, while CPR can be the initial basic therapy offered for these patients to support them before more advanced therapies are available, the usual advanced therapy required for correcting the rhythm abnormalities in these patients is a defibrillation shock. Now, defibrillation, I've shown you the hospital-based external defibrillators. We also have these devices which are called as AEDs. These are automated external defibrillators, which are designed more to be used by bystanders and general public. But the basic principle is the same. We have paddles which can be either metal paddles placed on the skin or adhesive paddles like this, which are stuck across the chest, and then a shock is delivered from the device. And like I said, these are the other external defibrillators which serve the same function, but are more commonly used in the hospital. And these are obviously there in every ward to treat patients who are prone to this kind of sudden rhythm abnormalities. However, while these work for a general population where people are unselected and everybody has a small risk of having a cardiac arrest at any time, there are certain patients who are selected patients who are at a higher risk of developing a cardiac arrest at some point of time. For these patients, the risk of dying suddenly at any time looms like the sword of Damocles over their head. So you can't predict when it's going to happen, and you only have to hope that when it happens, the defibrillator is nearby to rescue them. So one of the typical group of patients, one of the largest, the kind of patients who fall into this category are patients who had a prior heart attack. So when there's a heart attack, some part of the heart muscle loses blood supply for some time, so it dies. And then over time, this dead muscle is replaced by scar. And this scar tissue, on one hand, results in reduced pumping efficiency of the heart, so results in pump failure, heart failure. But it also results in electrical instability. So the heart as an electrical organ is also disturbed. And this electrical instability means that some of these patients are at a high risk of developing ventricular arrhythmias and dying suddenly. Now, it's fascinating how you need science, you need technology to develop new things, but sometimes in addition to this, there is a human element that is needed. You need somebody who believes that something can be done, who thinks and really decides that something should be done. So in terms of defibrillators, this impetus came with Dr. Mirowski, who's here in the white coat. So again, interesting story, because he was a Polish Jew, and he was actually fleeing the Holocaust, and so he finally wanted to settle down and work in Israel. He trained in cardiology before that in Europe, and then when he came to Israel and started working there, he worked with a senior called Professor Harry Heller. Now, what incidentally happened was that Professor Harry Heller had a cardiac abnormality. He was prone to develop these ventricular arrhythmias. So a couple of times, Dr. Mirowski saw that his mentor, whom he respected so much, had developed a cardiac arrest while he was in the hospital, and they could resuscitate him immediately with cardioversion. But like I said, these people, you never know when it's going to happen again. And indeed, it happened again at a time when there was nobody immediately to cardiovert him, and Professor Harry Heller died. So this made Mirowski think a lot. He knew this was a condition where, he's otherwise well, he's working, he's able to contribute to teaching and other things, but occasionally he has this episode of fibrillation. At that point, that can just be life-threatening. At that point, what he needs is to be defibrillated immediately. But he cannot be carrying a defibrillator with him all the time. So he said, can we somehow implant a device which can automatically recognize that this is happening and defibrillate the patient? So he put this idea around to his colleagues, but he was met with skepticism everywhere, because at that time a defibrillator was larger than the devices I showed today. So they weigh about 20-30 kgs. Nobody thought this can be miniaturized enough to be implanted inside the body. The whole thing looked like a crazy idea. But he was keen on pursuing this. So he went to the US, where he thought this is the only place where the facilities exist for doing this kind of research. And he found some collaborators, and they started working on miniaturizing this. Needed a lot of technology, of course, for the device to be first identify that an abnormal heartbeat is happening, for it to have a battery good enough and a capacitor to charge to such high capacities, how to deliver the shock. But they slowly worked on this. And when he first was able to perform experiments like this, where he was able to implant this device in a dog, induce fibrillation, and show that the device was able to successfully defibrillate, it was again something very dramatic. So they published this, and the initial defibrillators were again very large devices. They needed open chest surgery to implant them. And they also, during surgery, a large patch like this would be placed in the pericardial cavity. So this would replace the patches that we normally place on the chest wall. So this was a large, bulky device when it was initially introduced, and needed surgery to implant. Today, these devices have become much smaller, much easier to implant, and instead of putting patches inside the body, we have leads which are placed inside the heart, and the defibrillation is delivered from a coil in these leads itself. So the ICD today is basically implanted like a pacemaker. It is implanted beneath the chest wall, and the lead goes from here into the heart. And this is very similar to a pacemaker, but these leads, in addition to the pacing lead at the electrodes at the tip, have something called a coil here. And this coil is used to deliver the defibrillation shock between the coil and the cam. And various trials have shown that in patients who are at risk of sudden death, implanting these ICDs can result in reduction in their deaths. Because previously, none of the drugs showed that they could reduce deaths in this population. But ICD implants were clearly shown to reduce deaths in this population. So again, it has become a very routine method to treat these patients. It's not a foolproof solution. We still have a lot of questions on like whom to implant the devices really in. But again, when it comes to individual patients who are at risk, there is nothing that works as well as these devices do. So a good example would be something like this, which happened on live TV. So this is during a football match, and one of these players, you can see him collapsing here suddenly, was somebody who had ventricular arrhythmias and was at risk of sudden death. So he had some time before this got ICD implanted, and here we see him on the playing field. It was suddenly collapse, fall down. He had developed ventricular fibrillation and essentially was dying there. And if you will see this again, you can see him fall down, and in a little while you'll see his legs twitch. So you see that twitch, that is the device delivering a shock. So that's all the time it takes. It takes about 5-6 seconds for the device to recognize that there is an arrhythmia, deliver a shock, and that duration is short enough so that his brain has not been deprived of oxygen for a long enough period that he's able to sit up immediately. So that is this kind of, when you see it in person, it demonstrates what a life-saving therapy this can be. Otherwise, sudden deaths are one of the commonest causes of deaths in young athletes. So with that, I'll be finishing my talk, and we can have questions after that. The main points I wanted to bring out in this talk, and I hope I've sort of highlighted them properly, is one is to briefly introduce you to what cardiac electrophysiology is. It is the study and treatment of heart rhythm disorders, and especially to bring out how it is an excellent example of the synergy between science and technology. We really both went hand in hand without technology, we could not have done the science, and really science asked us what technology we required. And I've highlighted two specific conditions that we treat in electrophysiology. There are other conditions also we do, but two specific conditions. One are patients with paroxysmal palpitations, where today ablation procedures have become a very safe and very effective treatment with success rates exceeding 90 or 95% in these patients with an extremely low risk. And the other is sudden death, where selected patients who are at a high risk of sudden death, implantation of a implantable defibrillator called the ICD has again become a very routine procedure done everywhere now, and how it can be absolutely life-saving therapy in these patients. Thank you. That I'll close my talk.
Thank you, Raja, for that very nice talk, actually. We really enjoyed listening to this, right? It was actually quite watered down and not into a very technical kind of talk. And I really like the way that you brought the marriage or synergy between technology and science. And also, the stories are very interesting. So actually, when I was listening to this, it's not that stories don't repeat in medicine, right? If Rossman had to get the catheter inside himself, in 1980, our Warren and Marshall did the same thing so that they got the peptic ulcer. Maybe if you want to get a Nobel Prize in medicine, you need to experiment on yourself, I think. That is one. The other very interesting story or analogy which I could get from your talk was regarding orchestration by the scientific community, especially when you have ideas which are well ahead of time and they don't really understand what you're talking about. Same thing happened with our hand washing fellow, Simon Willis. So he was actually called as mad fellow, and he was also orchestrated by the society. Only
Right.
thing is, this happened before and the other one happened much later. But the story of science or story of medicine, I think, remains almost the same. The same thing we got. This was something which is very interesting to listen to in this particular talk. And the other thing which was very nice was the way you brought in the human element in whenever there is a change which needs to take place, or when you want to make a significant advancement. It is not that you need to have that idea, it's not that you need to have a need for that, but you also need to bring in that human element. I think that was a very nice part. And since nowadays that everybody keeps talking about multidisciplinary research, multidisciplinary approach to treating problems, so I think that part of it came out very, very well. Okay, and let me see if there is any question in the chat box. Yeah, there is one question. Uh, I have no idea. I think there is a student who has asked this question. Why IVs are offered in vein and not in arteries? Okay, I think that's a student from Cardiac Technology, if I
Right.
get that part.
Yeah.
Would you like? Yeah.
Yeah, I think probably the question they're asking is why medications commonly we administer in the vein and not in the artery. I think the arteries primarily go to a specific part of the body. So if you inject something in the artery in the hand, that what you inject will reach the hand really, right? And then after that, it has to go through the whole capillary system and come back to the veins before it reaches the rest of the body. So if you want to give something which should reach the whole body, you have to give it in the veins, because from the vein it will go into the heart and then it will get pumped out into the whole body. So that is why most things we inject into the vein. Also, of course, venous cannulation and puncturing the vein, etc., are easier and have less complications than puncturing or putting cannulae into the arteries.
The other one is from Vishnu Bhatt sir. Sir would like, he's actually congratulating you on an excellent presentation. And also he would like to know, are there symptoms other than, are there other symptoms that you think people should undergo regular checkup for identifying rhythm abnormalities? So that's Bhatt sir's question for you.
So, as you know, sir, like health checkups and doing investigations on normal people is always fraught with a lot of controversy and danger, because you're more likely to identify things and not know what to do with them rather than this. So especially with the advent of smartwatches now and this has become a problem because a lot of people, the device tells you have an irregular heart rate, you might be having atrial fibrillation. So I think especially the one rhythm abnormality which may make some sense to identify even when it is asymptomatic is atrial fibrillation. Because a lot of the people above 60 can have atrial fibrillation, and it is known that some of the patients with atrial fibrillation, it might be asymptomatic, and even asymptomatic atrial fibrillation has the similar risk of thromboembolism as symptomatic atrial fibrillation. So there is a theory that if you can identify these asymptomatic atrial fibrillation, and then depending on their CHAD score, if we find that their thromboembolic risk is high, anticoagulate them, then maybe you can reduce their risk of stroke in the future. But so you might be aware with Apple Watch, now there's some Apple Watch studies and all this coming up, how useful these devices can be to identify asymptomatic AF. The problem is that even if you have a small number of false positives, because the positives are the prevalence is small in the general population, finally your false positives hugely outnumber the true positives. So it becomes a bit of an issue. So far we don't have data proving that these really work, but I think that is one condition where I would say asymptomatic rhythm abnormalities. Otherwise, most asymptomatic rhythm abnormalities are often like PVCs picked up or mild sinus bradycardia picked up in an ECG. Most of those are benign and do not require any special treatments. I hope I've answered what you primarily wanted to ask.
Yeah, thank you. One more question which actually came to my mind is when you introduce or when you want to introduce technology, one is we can suddenly unleash technology like what the pandemic has taught us, right? You might be totally unprepared for it and totally it just comes upon you and unleashed in the general population. That is something I think what is happening with all this digital health monitoring, because practically the care of NCDs have gone zero. Nada. That's what has happened. So that is one. And the other one is we can do what is called as domestication of technology. You can use it in a smaller way and then internalize and it becomes institutionalized practice. So how did this change came about in cardiac technology? Or because the cardiology OPD we knew of in JIPMER as when we were residents, there used to be a lot of ECGs and there used to be a lot of treadmills used to go on, but sir will do a lot of echoes. And if you see any given point of time, he'll be surrounded by 100 people and you'll have to go wait half an hour to meet him and all that. So how did this transformation take place?
I would say especially for I mean, I think you're primarily asking about how now with the pandemic, how we have changed with technology. I think over the last few years, one of the things is it's become easier to take referrals in electrophysiology because ECG provides a lot of information for us and ECG is easy to share. So I think a lot of referrals now, at least the rhythm abnormalities, we can often get the ECG sent to us over WhatsApp. This happens both with patients who are in remote locations and also with residents and other people in other departments who want to take a reference from us. So ECGs are easy to transmit and give an opinion on. I don't know if that partially answers your question. And the other directly with patients, like I said, I think the recent transformation is with a lot of devices which record rhythm. So there are a lot of devices now which record ECGs, Apple watches, and a lot of Android watches, some bands. They record either rhythm or just record the heart rate. A lot of people have BP machines at home, and now the BP machines actually give you a heart rate. Pulse oximeter gives you a heart rate, and then the BP machines, some of them also have automatic AF detection. So we get more and more patient queries based on these. So I think those are this. But otherwise, the essential care we provide and the therapies we do, I don't think there has been a major transformation in what we do so far.
I was actually thinking about introduction of technology. How did it transform the field itself? That is what.
Yeah.
Okay. Thanks for
I think,
taking that.
yeah.
There is one nice question from Dr. Madana Gopal. You're seeing it?
Yeah. So he is asked about is ivabradine alone okay for sinus tachycardia? So sinus tachycardia, by definition, is not something which is pathologic, right? So sinus tachycardia means it's a tachycardia, but it is coming from the sinus node itself. And if it is, most of the time it is physiologic, which means the sinus tachycardia is there because either patient has fever, might have anemia, might have hypertension, or is just somebody who's exercising, running, or anxious. But there is a condition called as inappropriate sinus tachycardia, where some people's, it's like setting a thermostat wrong. So it's their control systems are not working well, and their sinus rates are always on the higher side. So again, by itself, it is not something that needs to be treated, but some of these patients with inappropriate sinus tachycardia may be very symptomatic. So for treatment of such patients, ibrahim is a drug which was just sort of relatively new drug. It acts on what is called as IF, which is a funny current, which is what underlies the sinus node pacemaker activity. So it is a very effective drug for inappropriate sinus tachycardia. So it is very useful in that kind of sinus node. So it is the primary drug that is used for inappropriate sinus tachycardia.
Thank you. There's one more interesting question. Can you permanently deactivate the permanent pacemaker? I don't know how many permanents are there.
So I can, So they've asked if you can permanently deactivate. So the pacemakers, generally what we do is these have what is called as telemetry. So telemetry basically means you can, and it's bidirectional telemetry, which means we can use a system. We have a machine outside and you place a wand over the pacemaker and it can communicate with the pacemaker. And we can have a two-way communication where we can deliver commands to the pacemaker and we can also read some data which is collected in the pacemaker. Now, the things we can change in a pacemaker include the pacing rate, various intervals, and the amount of current you deliver and things like that. And we can also measure the battery status and how the leads are, whether there's been any damage to the leads and so on. So coming to the specific question of whether you can deactivate, yes, you can. So just like you can change the rate and change the mode, you can put it into a non-pacing mode. So you can basically turn it off, and so that then the device would not pace. So it is possible if required to be done. And so there's another question there. I can see Professor Dr. Ashokan asking how many ablations are needed for WPW. So like I said, the RFA produces a lesion which is about 5 millimeters in diameter. It's really like a spherical lesion, you can think of it. And most accessory pathways would be smaller than this, which essentially means that one lesion should be sufficient to destroy an accessory pathway. So the minimum you would need is one. But sometimes if you're a little imprecise in mapping and you're not at the right spot and the first one doesn't get it or partially gets it, you might need additional lesions. So 1 to a few lesions, depending on the ease of that pathway and the expertise. But often you can get it with even just one ablation.
I see that our dean is quite interested. He'd like to ask some questions. He is a cardiac anesthetist by himself. Sir, over to you. You can unmute now, sir.
It was quite an interesting talk, Dr. Raja.
Yes, sir.
I have some question, totally might be beyond the scope of the talk that you gave.
Yes, sir.
It's see, ultimately, whether it is a myocardium or any muscle, ultimately it boils down to electrical activity, and which will be explained by the exchange of the ions across the membrane. Now, I have seen a couple of people, probably must have heard of these, the people who practice this Raja Yoga, these Brahmakumaris. They, almost 30 years back, when I had gone there, there was one lady who used to control her heartbeat at her will. Like, we all know that this autonomic control, you can't do that. But I have seen myself, I witnessed myself, wherein she used to, that means voluntarily can you have a control on this exchange of the ions or something of that kind? Because why I'm specifically asking is, as an electrophysiologist, how will you look at such a phenomena or a mechanism or a miracle or whatever you can say?
Yes, sir. Yeah, like you said, I mean, these, so most of the control of the heart rate would work through the autonomic nervous system. because like we know sympathetic stimuli would make the heartbeat faster, while a vagal will make it go slower. And these are some of these things we don't fully understand how yoga, meditation, or people even being able to specifically focus and control it themselves. But obviously there are people who have trained themselves and who can alter their autonomic tone or the autonomic output to specific organs and be able to control their heart rate. I mean, we can understand that it can be done, but it's obviously something that's not fully understood. And so the relationship of mind and body in this particular regard, I think primarily is mediated through the autonomic nervous system, but it's something that of course we don't fully understand and can harness.
Thank you, Dr. Raja.
Thank you, sir.
Yeah, I think that's all. I think we have questions in the chat box.
Right.
Okay, one more question because we still have a little bit more time. It is from me. I would like to know what is this? There is this, what do we call as low level of perceived stress, which is there, right? Perceived stress and low level of baseline stress is there. And currently, since we were discussing at the start of this program, how all these zooming in and out, no, the Zoom fatigue and exhaustion has set in. How does this affect the cardiac function, or what happens to the basal heart rate, the stress which is associated with chronic mental fatigue associated with Zoom syndrome, whatever.
So, I mean, this. I think it's been studied more with coronary artery disease. It's known as a coronary artery disease risk factor. Anxiety, type A personality, all these have been associated with higher risk of coronary artery disease. To some extent with arrhythmias also, but not as the primary cause. But in patients who are prone to rhythm abnormalities, emotional stress or chronic mental stress does precipitate arrhythmias. Generally a slightly elevated heart rate is the heart rate is the lower the heart rate is, the more healthy it is. You might know about the theory of how we all have a fixed amount of heartbeats for your life. So if your heartbeat per minute is smaller, you tend to have a higher longevity. So this goes across animals and also within different individuals in one species. So I think it's always good to have less stress in your life, but it's easier said than done, right? It's not something you can change that easily.
Yeah. On that note, we will close this webinar. Thank you very much for a very interesting and I would say it was a very enchanting presentation. And if I have to go by the messages in the chat box, I think there are quite a few messages which are congratulating you. And somebody has said that we thoroughly enjoyed your lecture. And wow, Dilip says that it is a beautiful lecture. And Dr. Srinivasan says that you have delivered an oration. Excellent illustrative journey of electrocardiophysiology. That is what was all these things. On behalf of the Scientific Forum and also the AVMC and Vinayaka Mission, I thank you, Dr. Raja, for accepting our invitation and delivering this excellent lecture. Dr. Bhatt, would you like to say something?
Yeah, I think most of the points he said, he made it very crisp and short and very specific, and I think he delivered what he wanted to tell. So I think it's a good presentation, and we learned a lot. And of course, we don't, as I started in the beginning, we don't think about heartbeat abnormality when it beats normally. When it disturbs, I think it's create problem. It could be emotional, it could be stress, it could be so many factors in addition to the disease condition. But anyhow, whenever you have problem, Dr. Raja is there. We can call him and ask to set the heart right. I congratulate you for a good talk.
Thank you, sir. I would like one small announcement for the participants. That finishes today's session. And next week we have episode number 49. That is, again, we will be exploring a little bit about technology. From heart, we are going to move to the brain. And then we are going to look at the evidence and experiences from perspective of neurocritical care and neuroanesthesia. What is happening to COVID and brain. So is this concomitant change or is it a consequence? What brain damage which is occurring? This is will be the focus of the talk. And next week we have with us the speaker from NIMHANS. It is Dr. Sri Ganesh Kamath. He's a fellow of anesthesia from McMaster University, Canada. And currently, he is working as a professor of neuroanesthesia and neurocritical care in NIMHANS. So he will be delivering this talk. And there is a small announcement for the participants. Since we were not very sure that 14th of this month can be Ramzan or 13th could also be Ramzan. So the talk had been fixed on 14th. So, but now that the holiday has been declared on 14th of May as Ramzan, I hope that you would still be able to join us for that next session. And even though it's a holiday, we will continue to host the lecture from our ends. So I hope you would be able to join. And that's all I have for you. And you will be getting the participation certificate link through your SMS. You can watch the YouTube videos of this talk, however many ever times you want to do. That also you will be getting in your message. And I hope you will join us next week. Thank you very much. Bye bye. Bye, Raja.
Bye.
Thank you. Thank you,
Bye.
sir.
Bye. Thank you.
Yeah. We'll be closing this meeting. We'll see you next week.